My name is Ulrich Koller. I'm from Vienna. I'm leading the sports team at the University Hospital. My boss is sitting over there, Professor Windhager. And I'm presenting today something a little bit about shoulder rotator cuff repair and shoulder arthroplasty. Just to know, this is like a lecture, so we have a lot of theoretical things. The first part will be rotator cuff repair. The second part after the break will be arthroplasty. For me, I'm now doing this for 17 years. And it turns out that it should be as simple as possible to judge if you do a surgery or not. So just wanted to know who of you is doing shoulder arthroscopy, shoulder surgery, who is focusing on that? Okay, and how much experience do you have doing a lot of arthroscopies or more open surgeries? Sorry? Arthroscopy, okay, perfect. Okay, let's start. For me, the most important thing is that you know everything about anatomy. And just to go back to our studies, we have to know that we have the shoulder girdle, and the shoulder girdle is connected to the torso just through the sternoclavicular joint. So the other things that are holding our arms in position are muscles. So it's a muscle secured joint. And that makes it for me very difficult to treat, because soft tissue is not that easy, like just putting a plate inside and hoping that it will heal or not. So you know we have the humerus, and here we have the sulcus bicipitalis. That's very important because you know what's running there. Does anybody know it? The long head of the biceps, and the long head of the biceps tendon is one of the most causing the most reason for shoulder pain. So that's very important to know. When the biceps here is running down, we have the pulley system over there. There is the supraspinatus. Here is the subscap. And if we have an injury there, we have to think, okay, is it just a ligament problem, or is it a muscle problem or not? So just to go through here, this is the capsular apparatus. And everybody knows superior, medium, and inferior glenohumeral ligament, and up there the capsule. And if you look inside, you see the biceps here with the labrum that makes the joint a little bit bigger, and where we have this compression effect of the muscles around the humerus. And this is very important for me, that you understand and that you know these structures can be damaged, and these structures maybe can be repaired if we are able to do that. If not, maybe surgery is not that good, or not a good indication. So when we have the muscles here, we see the shoulder girdle from the front. Here we have the short head of the biceps, the long head of the biceps, then on the back the triceps, and here the fossa infraspinata, supraspinata with two muscles and one muscle. Everybody knows that these are the four muscles: the supraspinatus, infraspinatus, teres minor. They are holding the humerus in place, and from the front we have the subscapularis, and those four muscles, they can be addressed when we are doing a shoulder surgery. So very important principles of clinical examination is that we know how long does the patient has. We have to make a very compact anamnesis, so we have to know how long and how much is the intensity of pain in this shoulder. Do we have any functional deficiencies? Was it traumatic, atraumatic, and is there what demands does the patient has? So we start with the inspection. When you look at this case here, you see that the patient here, I don't know if you see it, but there is a step inside. It's not a typical one for rotator cuff injury, but maybe everybody sees it's a AC joint problem. So you do an inspection, and you look if there is shoulder atrophy or something like this. Then you do a palpation, especially for the tendons now. I have to say that I'm an orthopedic surgeon, so we on our ward have a lot of atraumatic, degenerated patients, so they are much older. We don't have traumatic, or we don't have that traumatic, that much traumatic cases. I don't know who's doing trauma here. Most of you, yeah. And it is it separated in your country, trauma and orthopedics, or just everything together? Okay, it's separated. Ah, okay. Huh? Sorry. Yeah. Okay. Yeah, we tried to fuse. It is 10 years ago. It did not happen till yet. So we stay at the atraumatic cases and the degenerated ones. So for us, or for me, it's quite important to judge and to see that I don't have the problem that I have a trauma person, and so it's easier to palpate, to test range of motion, and to make all these provocative tests. So these are, for me, very important, that you know which kind of range of motion, and that you have a proper documentation of all these problems, because then you know how much is the range of motion. Are there any muscles, are there all muscles intact or not? And so this is easier for me to judge. So provocative tests, impingement tests, everybody knows. I stopped doing, to name it, it's the near test or not, so I know it's a positive impingement test when you have this typical impingement of the suprachromial bursa, where you have these inflammation and inflammatory problems. So you have to check this, because now we are going into detail where you just know, okay, he's suffering from a supraspinatus tendon problem, he's suffering from an infraspinatus tendon, teres minor or a subscapularis, or is it the biceps tendon? Because the next thing of the correct clinical examination is what? What kind of diagnostic do you do then? MRI or an ultrasound, so you get some help from the radiologist. So we have the near impingement sign. It's on the one side, it's the impingement sign where you have where you provoke the pain in the shoulder, or you can also do the near test, where you put some local anesthesia into the suprachromial space, just to know if the pain is coming from there or generated there or not. Then here I have these provocative tests of impingement, also again, where you just rub the bursa under the suprachromion or under the acromion through the humeral head. And if this is positive, you also know, okay, it's just an impingement, it's just the inflammation of the bursa. And yeah, so subscapularis test, I think everybody knows these tests, but I just wanted to repeat them, because I think it's very important to know, is the patient able to hold the arm in this position? Because if it is not that, if this is not the case, then I know which muscle has to be addressed during my next steps. So all these provocative tests, subscapularis tests, I don't know how many patients do you have in your outpatient clinic, because it's always a matter of time, in my opinion. So there is a lot of to do, no? Yes? A lot of patients every day. How many? Patients. How many patients do you see in your outpatient clinic?
Maybe 50 or 60.
Yeah. but not only shoulder patients. Yes. Or just shoulder patients? Oh. Yeah. So these tests are, for me, very important, where you just see, okay, this is due to the problem of the supraspinatus, like a supraspinatus test, Job's test, or drop arm sign, where you know the patient is painful when you have these a problem. But what I have forgotten now is in this lecture, what problem do you see when I just make this test? What do I test also? Or what can also cause pain when you're doing this? Yeah, internal rotation. And what happens when you do an out? Because the typical supraspinatus test, the typical one, is that the thumb is looking down. But what do you do when you are making it up? You make it outward, the biceps. So you can see when you just move, or when you just change the position and then you provoke the problem of the supraspinatus, you can also judge if the biceps is maybe a reason or not. Yes, here's the infraspinatus test. So we know all from these tests, all these tests are very logical, because what is the infraspinatus and the teres minor doing? Yes, and that's important to know. So external rotation for the supraspinatus with the abduction, external rotation for the infraspinatus and the teres minor, and this is the Hornblower's test from the teres minor. You're judging in 90 degrees of abduction. So when you can't hold it like this, then you have a pathological, or you have a pathology in the rotator cuff on the back. So what diagnostic tools do you have, or do we have? What are you doing? I'm doing the ultrasound. Yeah. Who is using the ultrasound? All of you? So all of you have time to make an ultrasound. We started to do in our shoulder, because we have a outpatient clinic for shoulder pathology. So we started to do it with an ultrasound, but we did it by our own, and it took a lot of time. So I think it's a very good examination, because you have all these kind of advantages, but it costs time. And what do we don't know from the ultrasound examination? And that's also very important, especially in the degenerated or in the old patient. Does anybody has an idea? We see we can judge the attachment of the attachment of the tendons, but what do we don't see here? Huh? Yes, the muscle atrophy. So that's for me quite. It's important to have an ultrasound, or it's very fast to have a diagnosis with the ultrasound, but I cannot judge the fatty degeneration of the muscles, and that's for me very important. Because why is it so important? The fatty degeneration.
It's trauma or not?
Yes, of course, but I don't. The patient knows if it is a trauma, or if it was a trauma or not.
If it's fatty degeneration, the muscle won't work even if you do a cuff repair surgery.
Yes. Yeah, for the surgical planning, exactly. For me, it's quite important for the surgical planning, because together with the range of motion, when I have a lot of fatty degeneration and he's moving the arm like this, then I'm wondering, why is he doing that? Or is that possible? Yes or not? Yeah. Yeah, we will see a little bit later. I will show you. But when I have an MRI like here, I can see, okay, we have a cuff tear pathology here. I have the synovial fluid. Then I can judge here, okay, that's not the optimal view, but I can judge here that the supraspinatus is intact, it is not fatty degenerated. Maybe it is not that far, or the trauma was not that far, or it is not. It is a very not acute, but it is easy to repair. It looks to be easy to repair. So the advantages of the ultrasound against the MRI is that the ultrasound is here, that it is easy, that it is you can judge the soft tissues around the hardware. It's a dynamic imaging, and it's a guided procedure, so it's very close. The MRI, you have to send him to the MRI, it takes time and so on, but you can judge better if there is the cartilage intact or not. So we also do the X-ray, all in these three positions, just to judge if there is, you see what here, what can you judge here? Yeah. The classification of this we will see then when we are doing the shoulder arthroplasty lecture, but you can see the acromiohumeral distance. Do I have here joint space narrowing? The tuberculomyos, when there is a lot of sclerosis, I can imagine maybe there is cuff pathology, because then the delta muscle is pulling up the humerus and causing this sclerosis here. So these are all important diagnostic things to make a whole story. Okay, so the rotator cuff now, we already heard that it's quite important to know which kind of muscles the rotator cuffs are and how big the footprint of the supraspinatus, the infraspinatus teres minor and the subscups are, because this is important for eventual repair, or just to know, okay, this is torn, but I think we can leave it how it is. For me, a very important thing is the rotator cable. It is this area here. Does anybody know the rotator cable? It is it's augmenting the rotator cuff and like a hammock here. And you can also see here it's a non-vascularized zone. But when you're going into a shoulder and you are doing the arthroscopy, then you see that there is often a synovitis in the rotator cuff that stops here at the rotator cable, and this rotator cable is just also a very is an augmentation of the rotator cuff here, supraspinatus, and it's attached at the beginning here of the tuberculomyos, and this is going back. So my question was at the beginning why I'm looking, or why I'm happy when the patient is having a supraspinatus tear and he's moving like this. Why is this? Because the cable is intact. In most cases, the cable is intact. When the cable is intact, then we have a very good range of motion. If it is not intact, then degeneration often starts here in the crescent part of the rotator cable. Then we know, okay, it's not that urgent to do repair. So we know degeneration starts here and goes back and to the anterior side and the posterior side, and the shoulder, or the function of the shoulder is still augmented by the rotator cable. Yes. So very interesting, or very important also to know, is that it is not just two separated parts, so that we have the supraspinatus and the infraspinatus. No, the supraspinatus is attached to the tuberculomyos, and from the back is the infraspinatus coming. The infraspinatus is then, when you do these dissections here, you can see that the infraspinatus is coming up here and is covering the fibers of the supraspinatus. So we know that we have an augmentation, and that these two muscles are confluent, and that's why they are compensate some issues for the other. Yeah? So this is quite important for me to know that you have this anatomy, that it is very confluent, because this is also very important for when you want to repair a rotator cuff or want to do or want to perform a rotator cuff repair. The prevalence and the rotator cuff problems, everybody knows, the older you get, the more common are rotator cuff problems. Risk factors are age, smoking, hypercholesterolemia, family history, and it presents with pain and sometimes acute weakness of the shoulder muscles and loss of active range of motion. Here, this is quite just how the patient presents. You can, I think it is, you already got a handout, so you will find these, and you can just judge which kind of these muscles are involved. Like I already said, we are, in my case, we are often confronted with degenerated chronic tears with chronic impingement. We don't have these acute avulsion injuries, and we are also faced to this or confronted to the iatrogenic problems because sometimes rotator cuff repair also fails. So the imaging here, what do you see when you see such a cuff arthropathy? But what are you looking now? For what are you looking now? Yeah. Yes. Okay. But it does not look so bad, or so we don't think that it's an arthrosis. Huh? Sorry? Yeah, but I think there is enough space between, or that's not that severe, osteoarthritis. But for me, important is that we have a reduced acromial-humeral distance. We have a very nice head of the humerus. There are no osteophytes here in the down there, and we see here must be some deficiency of the rotator cuff, because we also call the rotator cuff the shoulder depression system. So we have a reduced acromial-humeral distance. That's a sign for a supraspinatus tendon tear. So when you look at the MRI now, we judge here on the sagittal plane. What can we see here? That's a fatty degeneration. We see here fatty degeneration. We see here very the supraspinatus is should be this big. He should be in the fossa supraspinatus without these halo signs, without these fatty halo signs around. So this is very important. When you see it on the coronal plane, you see here the supraspinatus here lying in the suprachromial space. And as I mentioned before, here we have enough cartilage. No, not so much effusion. What makes pain, or what do you think? What makes the most pain here? You see it here, the biceps. Yeah. We also see the effusion around the biceps. That's typical for when you have it's a pain generator in the knee, in the shoulder. So for us, we send our patients, our degenerated shoulder patients, to the MRI because it's easier to judge now, together with the clinical examination, what are we doing now, or what is important to do and what not. Because you can fix everything, but is the patient happy afterwards? That depends on your indication. Okay. So what do you think? Is this fatty degeneration very severe here? No, I think it can be worse. Sometimes they present just with a little muscle here, then you know that here, and the tendon is not that much retracted. So, from my point of view, this would be a good indication for a shoulder of a cuff tear repair. Yeah? So we see here the Batman's classification or the Pate classification. It depends on the first. Yeah, when you look here, that you can judge the MRI, if we have an MRI, here it is completely torn supraspinatus, but when you look here, we have these kind of clinical or these classifications where you see or where you can judge if the lesion is inside, if it is inside, if it is a full thickness tear, partial thickness tear on the articular side or on the bursar side. So you have to know where you have to look for a lesion and what can be addressed. Yeah, that's the rotator cuff tears. The Ellman classification, you can do this Ellman classification at the beginning, but after some time, I think it will be common for you, and you will see, okay, together with the judgment of the fatty degeneration of the supraspinatus and the other muscles, and the grade of retraction, if it is possible to make a surgery or not, or what kind of surgery. Here are again described common types of rotator cuff lesions, but they are all in the hand out where you can have a look again. So these are common types of rotator cuff tears. It is the crescent part, lesion in the crescent part. Here you see the rotator cable is intact. So what do you think? Does he have a good range of motion or not? That for me, I think so too. Then we have the L-shaped tear. You see here the inflammatory the vessels, and that's here we have the hole in the tear, and this is the anterior part of the cable, and this should be refixed to the tubercular myas. And then we have these special forms of tears. So these are the options that we have for reconstructing these lesions. And there you can make a full repair, partial repair. It always depends on how stiff the shoulder is or how stiff the muscle is or not. What do you think, which kind of shoulder pathologies or what kind of tears should be treated? Should they all be treated arthroscopically or through surgery? No. We also start with a conservative treatment. What do you do as a... Injection. Yeah, injection, but what else?
Physical therapy.
Yeah. Why physical therapy? I mean, it's, I know we say it's physical therapy, but for me it's very important nowadays, after 10 years or 17 years, that you just tell your patient you are able to move your arms also when you have no supraspinatus. Because when the shoulder is stable and when the anterior and the posterior part of the cuff is intact, and you make a good physical therapy, is all the patients are able to move their arm, and then it just depends if they have problems with due to the impingement situation or not. So there can be the compensation, or the shoulder has a very high grade of compensating lesions of the rotator cuff through the other muscles. That's for me very important to know. Yeah, so non-operative treatment, yeah, it's very important to start with that, but also very important is to tell the patient the likelihood that the tear has a progression is high, and 50% of repairable tears become irreparable during this time. That is something that you have to tell your patients anyway. So what kind of operative treatment possibilities do we have? First of all, I mean, we have to do it in every surgery. We have to do a supracranial decompression. That means that we remove all the inflammatory tissue, the bursa, and then we have a look on the, or we have a view on the torn supraspinatus, and then we can judge is it repairable or not. I mean, normally you should go into the surgery and know the fatty degeneration is that far, the range of motion is very reduced, so the reconstruction will be quite difficult or not. But making just a suprachromal decompression is possible, and is with not that bad results. Here on this side, you can see. I mean, what this is? Which muscle? Supraspinatus, infraspinatus, and you see here this. Okay. Okay. You can see here, this is the retracted part of the supra and the infraspinatus, so the tendon part, and you can see it here on the coronal plane that the supraspinatus is very back on the heath of the glenoid, and can you just show that here? Yeah, and you see here, that's the same patient, that this is the infraspinatus, here at the front is the subscap, and that's the part of the supraspinatus, and it's very far retracted. So I think we won't be very successful with a repair. What kind of possibilities do we have? We have different kind of possibilities for the repair of the rotator cuff. We have just a simple suture. We can do it a double row, single row, Mason-Allen configuration, speed bridge configurations. It depends on which what technology and what company you have in your house. What do you think? Which one is better? Single row or double row repair? Yeah, double row is better. But quite interesting here, the speed bridge fixation. They did this group. It's an Austrian group. They made an investigation where they just used all these kind of sutures, and they found out that the speed bridge has a very high load to failure. Because they don't have it very good fixation here on the medial side of the road. So that's why we always start with a medial row where we also suture it so that we have compression of the medial road, and then just put the rest of the tendon through the lateral row down to the bone. So single row versus double row. Yes, double row repair often increased load to failure, better restoration of the tendon footprint, and with a single row you have a higher re-tear rate, and then there are new techniques like the transosseous equivalent double row technique, where you have a better tendon to bone contact, and so you have a better healing rate for the supraspinatus to the bone. That's very interesting, but for me that's always dependent how much traction you have on the tendons and how much how good the refixation to the bone is possible. That's how we do it here. That's a very young patient. You see he has a full thickness tear. He has less fatty degeneration of the supraspinatus tendon. What is this here? This is a sagittal plane. What is that? Here. Where do you think is the tear? Is it in the front? Is it in the back? He has a very good range of motion. No, subscap, that's the same, subscap would be here. Yeah, that's infraspinatus. And when you have a look here, that's all the same patient. The supraspinatus here has a a large tear, a full thickness tear, but no fatty degeneration of the subscapular, of the teres minor and the infraspinatus. And here you can see we have a full thickness tear, and this is the intact rotator cuff cable. And we now started to do a lasso loop technique, where an anatomic reconstruction where we have two sheets. You know, the rotator cuff has two sheets, and where we take the sheets, the articular sided sheet, and we put it down to the medial row, and then we put it, and the upper sheet, the bursar sided sheet, can be easily more brought to the lateral side, so that we have more coverage of the footprint, and then we have this kind of reconstruction, and that gives the best, maybe and a good possibility to have a refixation to the bone, and a better success. Yeah, there are a lot of techniques how to reconstruct the rotator cuff. The most important thing is that you have that the cuff has that you have a good reconstruction of the footprint, so that it is just not a single point, that we have more points where you cover the footprint with a tendon, and that you have enough pressure through all your sutures to the bone, so that you have a good healing rate. Yes, you know, different kind of techniques. I already said single row, knotless techniques, and so on. So this is depends on you what kind of possibilities you have, and it is triggered by what the company provides to you, but we have a lot of possibility for repair. Partial repair, what can, if there is no complete coverage of the footprint possible, you make a partial repair. It also has good results together with a physical therapy, but a re-tear is, or the risk of re-tear is high. Then newer possibilities is the patch augmentation. A patch augmentation can be with a cellular dermal allograft. So it can be synthetic autografts, xenografts. You can take a fascia lata. It depends how much time you have and what you want. So you put the patch onto, it's shown here, you put the patch on the repaired tissue, and it's a kind of augmentation. We did some kind of SCR with a superior capsule repair, but we stopped with that because it costs a lot of money. It is not with the best success rate, and so we did some of them. The performance was 50-50, and yes. Okay, and in the last option would be the reverse shoulder arthroplasty, and we will stop now, and we will stop after this summary. So the premier goal for rotator cuff repairs or for rotator cuff problems is that we first do a conservative treatment. Then we start, and with partial thickness tears, you should also do a rehabilitation first. But if the tear is too big, if you have a full thickness tear, the arthroscopic treatment will be recommended.